This is not in strict sense a callosal AVM, but a paracallosal AVM. So whatever I am presenting, this is also a conglomerate effort between a discussion which usually happens between me, Rahul, Dr. Trilochan. So before embarking on any sort of this AVMs, we usually try to have a prior understanding, and since this is a remote learning that we are having, we usually have to have some WhatsApp sessions or whatever, so that we understand better how to approach and how well to handle our materials. Because this, I was a Onyx user, then I am shifting now more towards glue, but now I understand again that there are some cases which will be for Onyx, some cases which will be for glue, because none is a permanent solution for all sort of diseases. That is my understanding. Rahul handles glue much better, so possibly he will handle more lesions with glue alone. So this is one example where we have used glue. So the first thing is, again, is not about your choice of materials and one short solution for every AVM or every malformation. So we have to understand that what we are dealing with. So this is a 12-year male, occasional headache, 3 episodes of focal seizure with impaired awareness, no focal deficit. So he has presented to us with this lesion. This is a contrast enhanced scan of the same patient. Now, obviously this is a AV malformation, not of the callosum, because the callosum looks clean, situated posteriorly. Now, this is the anatomical delineation of the lesion where it can be. So Rahul has just mentioned this endosium griseum. So it's more likely situated in this anatomical localization. And this is the phylogenetic circle that he always teaches us. So we try to localize this and try to understand where the possible feeders will come from, where it will go. So these are all okay. Now, once we are into the case, we see that which are the vessels that are going and how to delineate the sulci and the gyri, which are the ascending part of the vessel, which are the descending part of the vessel, which is the depth of the sulcus, which is the surface of the sulcus. So everything we can see if we understand. So this is while we were doing the case, this was not a microcatheterization prior to doing the case, but I thought that this understanding is important. So these are the vessels which play on the surface of the brain, and they dive, come up, and that is how they travel. So here we see that this is the terminal ACA and this is the PCA. So again, at the watershed zone of the ACA and the PCA, we have this AV malformation sitting. So this is again is the posterior circulation shot. This is the AVM. These are perforators which we thought would be important to show from the PCOM, not related to the case. And now while we were doing the case, then this was the tip of the microcatheter. This is the foot of the vein. This is a cortical vein which is going up, and ultimately it comes down to the vein of Galen, and from here is the straight sinus. So the next question is, it is a homogeneous thing or has it got multiple compartments? Because while using Onyx, the Onyx flows like lava, So if you have intercompartmental connections, there is a chance that it might start flowing into the other compartment. Whereas if you have two different anatomically localized compartments with their veins which are individualized, then there is less chance that onyx will actually percolate from one compartment to the other. So there, the advantage, so-called advantage of this onyx or whatever squid or minox, they get lost, because if you don't have those intercompartmental connections, then you cannot penetrate into the other compartment. So it becomes the same as the glue. Obviously, the time of injection and the laser of your injection becomes much higher with those agents. So this is another microcatheterization from the anterior circulation. So you have the tip of the ACA micro over here, and you have the tip of the PCA micro over there. So now, after taking these two different shots from two differently placed microcatheters, you will obviously understand that there are two different compartments, and the draining veins are also different. So though it looks a homogeneous tuft of tissue, once you do these microcatheterizations, then you understand that they are actually different compartments, and the whole philosophy of your injection becomes different. So you cannot again think of penetrating from one to the other possibly. So this is the ACA compartment, this is the PCA tip. So this is the PCA compartment. Okay, so this is the vein of the PCA, and this is the ACA compartment. I'm just playing it one after the other because to understand the spatial disposition of these two compartments. And now if we try to collate these two compartments, this will be how it looks. So this is the terminal ACA, PCA compartment. We have just shaded it out. So this is the venous compartment, foot of the draining vein, draining to sinus, straight sinus. Now this is the anatomically localized lesion. So Rahul is a master in putting all this into real terms, so we have tried to do it virtually. So this is the location of the malformation. So we have tried to juxtapose the this is the ACA compartment over here. Now what is appearing is the PCA compartment. This is the PCA shot. And now these are the venous part of the thing. So if we draw a cartoon now, this is the ACA, the ACA compartment, the PCA, the PCA compartment, and these are the venous part of it. So now the important question comes that the patient has not bled, he is a 12-year-old, preserved. Do we need to treat? So having known that this is a fistulous AVM with a venous ectasia, possibly yes. So we first started with the SCA compartment. We tried with a 50% glue because it was a high flowing situation. However, even with 50%, we were constantly going into the foot. So we stopped our first injection here. Once we found out that a large amount of glue has gone into the venous part, and we came back. So this was the post first injection. So why did it happen? Why did the glue flow so fast? Though we were on the higher side of concentration, we used 50%. So this is again his picture, his teaching, that when it's a fistula sort of a connection, it flies off very fast unless you were wedged eccentrically. So even 50% would fly off. So that is what has happened. So possibly our case had this sort of a fistulous connection within the nidus. So possibly the solution was more concentrated glue to the tune of 80%. We were afraid. Now we came back to the posterior circulation, the posterior compartment, and we put up our microcatheter there. It was all along there, so we started doing the posterior compartment. So this is the tip. So here also we went ahead with 50% glue, and we could fill this entire compartment and the foot from the second injection. So we took off the compartment exclusively supplied by the posterior circulation, and then again returned to the anterior compartment. By then, because we had percolated the compartment, the flow has got slower. So here again we went ahead with a 50% glue injection, because this is now a modified scenario where the flow has been going down. So we are not in that previous scenario where it was very fast. So we didn't change our concentration of glue, we still went ahead with 50% of concentration. So the third injection was more controlled, we had more time, and we could penetrate a lot better. So this was the final simultaneous injection from the anterior and the posterior circulation taken together, where you can see that this is now isolated from the circulation and there is no late venous flow. So this has been taken care of, and the SCA is and the callosal system is preserved, and the posterior circulation. We saw these two vessels, we marked them out, and we could find that at the end of the session they were perfectly preserved. So there was no reflux from this. So this is the glue cast. This is the these are the vessels that we just. This is the glue cast. The sinuses are patent. So where is the glue? This is the area where the malformation was, and we finally confirmed that with imaging. This is a small infarct which has happened, but the patient didn't realize there was no deficit. So going back to the CT, this is the area of the glue cast, perfectly in position where the original lesion was. So the outcome was total obliteration of AVM at 6 months, no nerve deficit, on single AED, and no further attacks. So take-home messages: even in the absence of bleeding, we need to intervene at AVMs which are harboring intranidal flow-related aneurysms, venous ectasias. Every AVM is different, and selection of embolizing agent, and that too in right concentration, is challenging. Thank you.
Excellent case, Dr. Deep. Any questions? Any discussion? Any questions on this AVM? Nicely done case.
What do you think about cyber knife in this case?
Yeah. No issues, absolutely.
So the patient, why did you get an MRI? Because you were not suspecting any infarct. So it was just for a follow-up thing, or like, why did you get an
Yes,
MRI?
absolutely. It was just a follow-up. We did a CT, and to be truth and honest, since this was done in a teaching institution, the imaging modalities are more or less very less costly. So we checked, that's all.